Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and entire tri-state community. Tonight we have a very special topic. We're going to talk about optometry. And I have one of the best optometrists I know, a very good friend of mine, and actually the best man at my wedding, Dr. Ed Ruvio. So thank you so much for coming.
Thanks for having me.
And we're going to sort of take the mystery out of eye doctors. Mm-hmm. And you're a doctor of optometry.
Yes. Mm-hmm.
And tell me a little bit about what an optometrist is.
We examine the eye, not just to see, but to enhance the sense of vision to its utmost. We also diagnose diseases. More and more, we're getting more and more ground to be able to treat diseases. And New York State just finally joined that and let us do oral medications this year. That was the first in New York. But we enhance the vision, the functionality of vision, like you have your glasses on to be able to see near and far, and that's what we take care of.
So basically you take care of the eye.
Take care of the eye and manage, diseases, diagnose diseases, watch stuff.
So the different words, mm-hmm. and help me understand a little bit.
Yeah.
So there are ophthalmologists,
mm-hmm.
and a lot of people think about the surgeons and cataract surgery. Mm-hmm. What's the difference between an ophthalmologist and an optometrist?
Ophthalmologist's main training is disease management. He's an MD like you. And if there's a disease of the eye, surgery of the eye, manage diseases, glaucoma, if the retina tears, many different diseases, that's what they're trained for. And it's about an inch or so long, but there's many specialists for ophthalmology from the front into the back, and they take care of the tissues, they manage the tissues, they treat it, watch it. Unfortunately, not everything you can fix in an eye, it's all nervous tissue, but that's what it is. Some guys do the front of the eye, the cornea, and those are the people that do the LASIK surgery also, that they're augmenting the cornea. There's doctors that do cataract surgery, then there's retinal surgeons, there's retinologists that do the back of the eye.
So whatever part of the eye.
There's a specialist, parts. A lot of them do it all. There's group practices that have ophthalmologists for each thing together. A lot of times they'll also have an optometrist in the office to take care of the functionality once the disease is managed and to see what kind of quality of vision is coming. And that's
so you use that term a lot, but and I want to sort of translate for the public, mm-hmm. for our wonderful viewers. So the question comes down to is, when you say that, tell me a little bit about refraction. Mm-hmm. So when you say functionality, and again, I wear glasses, I've worn glasses mm-hmm. since I'm 3, and you're the one who refracts my eyes, and I am able to see because of that. So tell me a little bit about when you say functionality, mm-hmm. And I don't want to make it so simple that you're the person who tells me what kind of glasses to use, or writes a prescription for it. But when working with the ophthalmologist as an optometrist in that setting, mm-hmm. or even in your business, your store, tell us a little bit about what you think the optometrist really adds most to.
We figure out what the state of refraction is, either the nearsighted, farsighted. You throw astigmatism on top, which is also blurs.
What's astigmatism?
Astigmatism is caused by somewhere along the eye. A camera is almost like a simplified eye, but the eye also has a brain connected and processing and everything. But curves make power. A windows is perfectly flat. There's no power to a window. Magnifying glass is very round. Lots and lots of power because there's more curve. Curves make power. What astigmatism is, instead of being perfectly round, if you took the ball and squeezed it a little bit in one direction, it's going to be different curve that way than that way. That's two curves, the different curves light's going through, and that blurs the image. Then we got to specify the glasses to be shaped equal and opposite to offset that difference, and that clears the image coming to the eye.
So when you talk about refraction or the prescription mm-hmm. for the eye, that's contact lenses and glasses.
And glasses, yeah, because we need to know what power to get the image right on the retina. If you're nearsighted, the image is in the eye. It's too short. The eye is longer than it needs to be. The back of the eye is almost like the movie screen. Mm-hmm. When they show a movie, it has to focus on the screen. If the projector's blurred, not focused in the right spot, the image is blurred. Same thing with the eye. If it's images here, focus here too long, or too short or too long, it's not focused right where it needs to be for the brain to pick up a nice sharp image and process.
So we want it to be perfect.
You want it to be there. And refraction is how we augment the light coming through to be right at that spot.
And what's an optician?
Optician, he's going to take the prescription, and now, depending on your needs for that pair of glasses, he's going to pick the right lens, the right frame so it's fitting right, specify what lens you need, and also take measurements so you're hitting it all in the right spot. Just like if what you wear and I wear is progressives. And that's a whole lot of powers through that. You have to be able to hit the right zone for when you're looking far, looking down at your computer, and reading. And that whole situation has to be in the right spot. And he's going to manufacture that. He's going to specify where that is. That has to be within a half a millimeter. We specify it up and down, side to side, so you hit it correctly.
So it really is a team approach.
It's a team approach. There's overlap, but there's differences. Like I'll take my patient's frame, adjust it, but I'm not as good as the optician. That's what they're trained for. But he's going to take over for where I'm not trained as much. He'll do that. I can't make a pair of glasses. He can or she can, and they'll adjust it better than I can. With ophthalmology, the other way, I can deal with some diseases, but then if it's past my scope, that's the ophthalmologist. So it's a whole spectrum.
And it works the other way too. The optician doesn't examine the eye. The ophthalmologist, I've been to many, and many are very good friends, they really don't refract.
No, they're not trained. Secondarily, they're trained that, but we're trained for the refraction to focus, to enhance the sense of vision to its best.
So if someone was going to go for their yearly eye exam, and and the word routine is never routine.
Yeah.
But if your eyes are so important to be able to see and do everything that we do with them, who's the person that you would recommend or it's recommended to go to?
Well, optometry is primary care. So you're going to come see us. Not that I'm leaning towards it, because I am, but we're on the primary.
So we do that with medicine too. Primary care doctor, and then there's subspecialists like neurologists and things like that.
So we're on the primary care end of it. If there's a problem with disease management, off you go to the ophthalmologist to take care of that. If you're happy, healthy eye, and I get the proper prescription, and I spoke to you what you need and the needs for this with a pair of glasses, then I send you off to the optician.
You speak about it with such vigor and enjoyment.
I enjoy what I do.
And I love what I do too.
Yeah.
So tell me, why did you become an optometrist?
I was always a science guy, and I love science, and always, my mom was always in the healthcare industry, and I knew I wanted to be in healthcare, and this is a beautiful part of healthcare. We get to help people directly, right there, right as soon as they come in, and it's a very important sense. All the 5 senses work together, but this is a very important one, and it's just a beautiful part of healthcare.
And to say that we went to college together.
We went to college together,
and how proud I am of you, and how really.
And I'm proud of you. You're one of the most brilliant people I know.
Thank you. So tell me, so your family has a store?
We were all together in business, my brother and I, and when we started out, it was my mom and dad also, my sister-in-law, everybody was we all started it together. And we grew the business. My brother was the first. He's older than me. He was an optometrist, and that helped also because he loved it. And when he was doing it, I said, I could do that too. And I really enjoyed it. I was helping there when I was in college, and just was in the field even before I was an optometrist.
Anything that I'd be surprised about with someone who has a store and basically providing medical care. It's sort of interesting. I mean, now that urgent care centers have sprung up where people just walk right in.
Yeah.
Usually in my office, people call up, they make an appointment. It takes a little. Here, it's a little bit more direct with the public.
Well, we do appointments, but we also do walk-ins, and it's a full service. You come to see me. I'm a doctor. I have my room. I do the health care, but we're also in a setting of a retail. Full-blown dispensary with glasses, contacts, and it's a wonderful mix because I get to do all the healthcare. I love my patients. I do as much as I can, and then we can fit them with the product, and we make sure they get a good product. And it's a whole different side. It's service and product. It's a wonderful doing the both.
Well, that's so interesting. So, how does someone know? And this is a tough question. When there are a number of stores that have that sell different brands, different large
different
companies,
names and everything.
I think you guys are eye to eye.
We're eye to eye.
But I mean, there are some big chains. Maybe that's the word I'm using. How do you know when it says there's someone there that they're good or qualified?
You could be in a chain that has a bad reputation, but if the person cares, You'll get good care. But you have to go in and really trust that person, but you have to ask them. When you walk in, you have to see, is this person there for me or for themselves? They're going to ask me questions, and you can't read somebody's mind. You have to ask questions, and the first part is with the case history. That's so important with any medicine, during the case history, to see what they need, what they want, what their expectations are, why they came in. And you have to be able to fulfill that. And the patient should also sense it. Is the doctor really caring? Is he listening to what I want? Does he understand what I want? And then you go forward from that. And when you walk into a place, you have to know, is the salesperson, is the receptionist, are they there for you? Are they paying attention to you, asking you questions? Want to know why you're here? Or is, you're bothering me? Or how much money can I get from you? That's the wrong side.
And just as you said, it's like you're the primary care, so it's like any healthcare professional, word of mouth, other people seeing you.
And that's the best you can do as referral. That person puts their reputation on line to recommend you. And if they had a good experience from A to Z, they're going to send it. If they're not, oh boy, they're more vocal if they're unhappy than a happy patient.
Let's look, we brought some models with us. Let's look at the eye.
All right, here's half an eye.
Okay.
And what this does, this is from beginning to end. What goes on here, the cornea, this is the first part. That's the clear bubble over the colored part of the eye. This does a lot of the focusing. It's not just a place where you lay a contact lens on. It's not anything. This has a lot of the power of the eye, a lot of the focusing of the eye. Then there's the iris, like a camera. You open and close the shutter. How much light goes in. At dark, it opens up. When it's very bright, it gets less. That way, it protects the eye. That's why your eye hurts when you go in the sun. It's too much light, and the iris is like the shutter of the camera, open and close to let the amount of light in. Then behind there is the natural lens of the eye. This main function is changes focus. Like if I was to take a picture of you, it has to focus. And then if I want to turn around, take a picture with a camera of a tree, I have to refocus it. This is our autofocus system. It changes. It's not a muscle, which a lot of people think it is. It's connective, clear skin tissue. And that focuses back and forth in and out, except until after 40. Then this becomes a thorn in our side. Because all of a sudden, after 40, since it's the skin tissue, it starts to become less elastic like all of our skin. And what happens? We start doing that. And then we do more. I can still see it, but this is not focusing as well. That's when we start needing reading glasses, when this begins to be less elastic. But all this in good working order, the light goes through that, and then hopefully it focuses right on the retina. And then it's a clear picture. But again, as I was saying before, if it's out of focus, if it's focused here, or virtually it'll focus here, it's not focusing here, it's a blurred image. So then we put either a contact lens or a pair of glasses here to help the eye aim the focus right on the retina, right on the movie screen.
And it still takes the brain to perceive vision.
Then it's a gazillion different nerves. When we look straight ahead, there's certain nerves that sense it becomes sharper, it senses color. As you go away, it takes more motion. It also is not as sharp, but that's all the peripheral vision rather, and that also senses motion, just even evolutionary back to seeing an animal coming to get you.
So tell me, you pointed out one structure that I'm familiar with, the lens. Tell me, when someone needs a cataract, the term cataract surgery,
that's the second hit of this lens in here. Right. That after it stops becoming as elastic, the next thing it starts to opacify. It gets cloudy, and it gets cloudier, and it gets cloudier. When it gets too cloudy, that it inhibits the light to get through, then we call it a cataract. And then eventually they take this out, get a nice new clear one, and implant it back in there instead of this one. And then you see clear again. And that takes about 15 years or so to get cloudy. And once you get that done, if the eye is healthy and no, God forbid, other things happen, you see better than you have before that cataract surgery.
It's funny, when someone goes for cataract, has a cataract, oftentimes they'll have it on both sides.
Yeah, because we got two eyes. The tissue doesn't always go the same speed, but it's a natural change. Our hair gets gray as we age. The lens gets cloudy as we age.
Right.
We can dye the hair. We can't clear that.
Can't do that.
Yeah.
And I know there are different kinds of lenses, and again,
now they're playing with bifocal lenses. You can see near and far at the same time. That's not always the most successful thing. Some people don't do as well. The most common thing is they put a lens in, try to figure out your prescription, and you see clear far, and you need reading glasses like you always did.
I know you do a lot of screening in the store, in your office.
Yeah.
And part of the screening is for increased pressure. And people have heard the term glaucoma. And glaucoma means really increased pressure in the eye. And a lot of things can cause increased pressure. If the tear ducts don't, if the tears don't drain.
No, it has nothing to do with the tears. It's all internal eye fluid.
Oh, so
there's constantly fluid internally made and drained. It's made, it goes through the pupil, it's supposed to drain right behind the pupil and back out into the blood system.
So does it have to be a blockage to get glaucoma?
It could be either too much production or too little drainage. And even if the drain area is a little narrower, that can cause certain types of narrow angle glaucoma, where even some debris over time gets in there, it can clog the drains. And now it keeps being made, but it can't drain. It pushes pressure onto the whole thing here. And then the disease of glaucoma is that too much pressure is put onto the nerve at the back of the eye, and it kills it. The blood can't enter it, so all of a sudden it starves of blood oxygen, and the nerve fibers die.
And how do you test for glaucoma?
Pressure. The first thing is you test the pressure in there. Either a little puff of air, a little probe touches, and it feels the resistance, and it tells you about the pressure. Sometimes people's cornea is a little thicker, a little more resistance. You think they have glaucoma, but then you do further testing and you rule it out. But if it is glaucoma, it's a progressive disease, asymptomatic most times. Because
so asymptomatic means that you don't know you have it.
You don't know you have it because there's no nerve endings inside the eye to feel pain or pressure. So this pressure is building, mounting up. You have no idea. It's killing off the nerve, but it kills off the peripheral vision first. And then as it progresses, it narrows down. So it doesn't even do anything to your sharp vision till the last stage. The last stage starts attacking the central vision. But even you have a little tiny island of vision, you may not notice it for the other eye's not being afflicted. And then all of a sudden, that goes out. And even one of the first symptoms is clumsiness. Because you lose all the periphery, you start tripping over things. That sometimes is a symptom of glaucoma if it's both eyes.
I know you have some pictures, so we have some wonderful diagrams that we wanted everyone to see. And you take pictures of the eye.
We take pictures of the eye. We get to see the back of the eye. In the back of the eye, you get to see the nerve. You get to see the cardiovascular system. That's the only place that without cutting, x-raying, dye, and x-ray, you can see the cardiovascular system right
so you
at
can
the back.
The only place you can see a nerve.
Nerve.
And the only place you can see an artery.
Artery and veins. It's all the back of the eye. All that's there. All that information is there.
So show us some pictures. We love pictures on the show.
We love pictures. Okay. There we go. So this is a normal eye. This is the back here. And what it is, you get to see the back of the eye, that little dark area right there. That's when we look at something, that's what we aim the center of the eye. That's called the macula, the fovea. All the sharpest vision, the color vision's there. All the outer part is all the peripheral side. But here you see all the blood vessels are normal. The veins and arteries are all the right caliber. They're all pumping blood. They all look normal. And all those nerves bundle up right there. That's the optic nerve right there. That's where everything comes together and leaves to go to the brain. And that's the nerve that gets killed with glaucoma because too much pressure, so all of a sudden this nice pink tissue, which has a white center, all starts turning white as all the nerves die.
No, and I see that as an MS specialist, there's inflammation of that nerve.
Yeah, because MS, it affects the nerve, and you may not see it in the eye, it may be further back, you may see it on the eye.
Exactly, so we see this in different disease entities too.
Yeah.
And as you said, even the cardiovascular system is seen, you could tell if someone's got elevated cholesterol, high blood pressure, all kinds of other things.
Yeah.
So show us what else you have.
What else do we have now? Too much, it went away.
Live TV.
Live TV, look at that. Go talk amongst yourself.
Okay.
Where's the pictures?
So I think we have the picture for you actually on our screen. And really what the pictures are showing is glaucoma. And here's, actually we have this, look up, we can actually do it from
That's
that.
a picture of diabetes. All the vessels. Diabetes is, people think it's the pancreas. It's a cardiovascular disease. That's why it affects the entire body, the feet, the kidneys, the heart, the eye. Blood vessels don't work. The sugars is poison to the arteries, the blood leaks out, so now the artery doesn't get to the end stage. So it starts to react to grow new vessels to try to make up for it. And those grow through all the healthy tissue, and if it was up close, you'd see all these blood vessels growing over the nerve, growing everything, and all the blood coming out, all that hemorrhaging around the side, that's all blood escaping, and that's why people lose fingers, people lose feet, because the blood doesn't get to the end, and we get gangrene.
And some of the treatments, they have laser therapies and things like
what
that.
they do, they shut down those new vessels start growing through the tissue. They zap them down so they stop the growth. But it's an ongoing thing because it then tries to do more and more. You cut a branch, it tries to go new stems, and the blood vessels try to do the same thing to compensate, but they grow through healthy tissue.
So wonderful pictures. So now I'm going to go back to some topics that I think I'm interested in. I'm sure our viewers are interested in. This time of year, people are always interested in sunglasses. Do we need sunglasses? Could you go to the dollar store or whatever it is now?
You gotta be careful because not all sunglasses are the same, and for different functions and stuff. You get a dollar store sunglass. Right. It costs 1/10 of a penny to put a UV sticker on it. They may not absorb UV. UV is what we get sunburn with, and that's the harmful part of the spectrum. Cancers, everything. It does push cataract formation forward. It's bad on the eye. The macula, the very center, it helps to create macular degeneration also. And what happens, you darken the light in front of the eye, the pupil opens up. And if it's not a good lens, you get even more UV into the eye if it's not a good lens absorbing UV.
So do you recommend sunglasses for
sunglasses, people go outside, and then for different things, if you buy the water, you get all that white, crazy sheen off the water. That's scattered light. Light hits, and then it comes out in every direction. And that's that mad scatter, that glare and everything. Polarized lenses, they take that mad scatter. It's almost like you're looking through a picket fence, only light in one direction can come through. It cuts out all that glare, and you get a much clearer image coming through. So not only is it dark, it just gets rid of all the glare off the hood of your car, or off the water, or flat surfaces. It does that polarization. Again, if by the water, by the beach, that helps there. You're a golfer. There's certain things that help with golf, even on a sunglass. Golfers, they don't want a gray lens, they don't want a green one, they want a brown lens, because brown helps bring the contrast up, because gray minimizes contrast. And if you're checking out the putting green and the contrast and everything, you might not see it. A brown helps enhance contrast. So they want a brown lens, they want a polarized lens so there is no glare, and you want a good anti-glare coating on the back so you don't get reflections of everything even behind you or see your eye blinking. And that, golfers, that's how specific you can get for golf.
So that's how important all those things that we think might be. Do you want this? Do you want that?
And that's again back to the importance. Are they somebody selling at you, or they're asking, what do you want with this pair of glasses? They're making sure you get what you need instead of they just going to sell a pile of whatever at you and not care. It all has to be back to the other question. What is this for? What's the main purpose of it?
How about lenses themselves? I mean, it's nice that we talk about sunglasses, and that includes people who don't have to have them refracted either.
Yeah.
These are just lenses.
Plano, we call plano, no prescription sunglasses. Yes, it still gets the glare out, cuts the light down, makes you much more comfortable. Driving, you're not with the glare you can see. Even at night, there's certain glasses. These headlights now, these halogen and these LED headlights, and people, but brighter than it should be, coming at you, it's debilitating. Right. And even now there's some yellowy lenses with an anti-glare, so it takes the white into more of an amber. It softens it, but doesn't cut the contrast. You can't wear sunglasses on that. You won't see little old ladies scrolling and walking in front of you. You have to see them. But it's not going to make everything dark. It's just going to take the bright white into a yellow, and then you have a nice anti-glare, so you're not getting starbursts of every light also, so it makes it comfortable. Like even on yours, you have an anti-glare because I'm not seeing myself.
Oh, okay.
It makes the light go through instead of bouncing off the surfaces and creating double images and triple images.
Oh, it's interesting. See, it's funny. Every specialty, I've always seen it. Whenever a friend who's a plastic surgeon will tell that person has this, this, and this.
Yeah.
You can tell from the glasses themselves what people are doing.
Yeah.
So tell us, when somebody gets over 40.
Yeah.
And you started talking about the lens and the,
It's called presbyopia. It's even got a name.
what happened? Presbyopia means you're getting older.
Yeah.
So tell us a little bit what happens. Why do people feel like their arms are not long enough or too short?
Because when we first hit 40, we're in complete denial.
Right.
I'm not getting older.
Right.
Not me. I can still see. They're making it darker in this restaurant. They're printing that smaller. But no, it's that lens loses its function to be able to change shape to focus in and out. And that's when, even if you can see perfectly all your life, you get to 40-something, you're going to get a little help for reading. But with a reading glasses, focus up close, not for far. So you'll be able to read, but you look up, they have to come off.
Does everybody need glasses eventually?
Well, we all
Or are
run
these
into
refractive?
presbyopia, that we lose the ability to change. I'm not wearing anything now. I'm not so perfect far.
Right.
And where I can see far, but I'm not going to bump into things, but it gives me the leeway to see up close.
Right.
But when I need to see really well up close or to see far better, I have, like you, a progressive.
Tell me a little bit about contact lenses.
Contact lenses, they're in contact with the eye.
Right.
And so if you're playing, if you want to see nice and sharp, and you wanted the glasses for playing sports, they work great. But they don't give you a physical barrier. Like if you're playing with a small ball, you have to wear something over because the contact won't give you any protection. Glasses, a little protection, but it can come at you, and your injury could be the shape of the lens that comes at you. So
have they gotten more comfortable over the years? Are they?
Oh yeah, it used to be back in the 80s, 90s. The materials, they were this plastic, and even though they were soft, they weren't very oxygen permeable. So you put it onto the cornea. This guy here. You put it there. There's no blood vessels in this cornea. It breathes out of the atmosphere. Your skin, all that, we bleed a lot because all the blood vessels underneath feed to the skin. But the cornea doesn't have blood vessels, so it breathes out of the air. And the older materials wouldn't send enough oxygen through, so it would be depriving the cornea of oxygen, and the cornea didn't like it. So it would grow blood vessels in to feed it oxygen. It swells, all kinds of stuff. Now the materials for the past good 20 years, much more than enough oxygen gets through. And now the race is to make them more and more wettable and everything.
To make it feel more natural.
More natural, keeps it not getting dry. Because when we really contacts, if we're looking at a computer, most of us do, we tend to stare. We don't blink when we're on a computer. We don't blink spreading the tears around. And lenses get dry. But now the new materials, they're better. They try to hold more.
In our last 30 seconds, tell me about computers. Everyone is doing everything virtually. Everyone's on the computer. You know, my kids, the size of their
it's all in our hand is our computer.
So what should people do to be able to see better with
They
that?
need to pull the nose out of the screen once in a while, because when you're really on a computer, we don't blink. As soon as you look away, you're going to start to blink. You're going to release the 6 muscles on the outside of the eye, which are pointing to one thing. Those are the most over-engineered muscles in the body. They're strong, but they do need a break once in a while. And as soon as you look away, you're going to blink, you're going to look around, the focusing system's going to release back out, go back in, because if you hold up something heavy for a long time, you're going to drop it. You put it down once in a while, pick it up again, you're going to go longer before you're totally...
When we started, you said 30 minutes is a long time. We've actually come to the end of our time. And I think everyone has seen that you are a true expert in your field. It is a pleasure to have you on my show. And I have to say, it's an honor to know you, and it's been a pleasure to know you.
You too. We've been friends, and it's been an honor to know you for, too many years. We won't even say.
So I say goodnight to everyone, and we'll see you soon.